like increased stress vulnerability and increased sensitivity to substances. What are the therapeutic implications? Well, when we look at the therapies and the factors which are important in therapies, engagement in a meaningful relationship and engagement in meaningful activities is a big factor. Actually, just the interaction with the therapist often accounts for up to 80% of the effect. So I think that is often underestimated, and I think we need to do more research into this factor because it seems to be like a huge factor, and since the interaction is often based on most often based on the interaction with the treatment provider, this is, so to say, the basement of any intervention. Not anymore, because we do have computer provided treatment options, but in current studies, this is a big issue. What I would suggest is actually that, and that comes more from the clinical part, and you have seen data before today, which also support this so to say, baseline for treating comorbidities, is an increase in stress resilience. And I think what it also means is that if we can increase the stress resilience or decrease the stress level and stress vulnerability, we will also have an impact on impulsivity. And I think actually one of the misconceptions is that impulsivity is a trait. There's certainly part of impulsivity is trait, but there's also a large layer of state impulsivity. And I think by increasing the stress resilience or lowering the stress vulnerability, we also may have an impact on impulsivity. What are the stress management approaches? Some of them have already been mentioned: time management, problem solving, relaxation, which obviously is harder for some, as we have heard before, behavior modification, cognitive restructuring, biofeedback, medication, mindfulness. I think it's often taken as so to say, a helpful addition, but I think we have to consider this as to be one of the bases. And some of it might be helpful, but we have to think of how to approach those we cannot reach with these methods. The next is normally what we look at as disorder-specific interventions and medications. But what I would suggest is actually to also consider, and this has also been kind of indicated before, to look more at specific deficits. You can measure these specific effects like error monitoring, reality testing, and you can try to target these specific areas, like when you look at error monitoring, remediation of compromised interoception, impaired self-awareness, and insight into illness. In the 70s and 80s, actually, people tried to improve this insight and self-awareness by such things as a video camera and biofeedback. And I think that is an approach which is pretty much neglected currently. And we are seeing from other studies, again from Bechara and others, that the kind of impaired self-awareness and insight seems to be a big factor in substance use. And if you can have an impact on them, that would be very helpful. And actually, I think we need studies to look at if we can really use these methods to improve these aspects. If we top-down guidance of attention and thought, mentioned has been already mindfulness. There was recently a study which suggested just going 2 to 3 steps backwards before starting to discuss something is an easy way, which seems to have an impact on being able to approach something more cognitive. Medication, I don't have the data for that, but one interesting aspect of acamprosate is that the retention, it had very little side effects, and it was effective in treating alcohol dependence. But one of the aspects which was not clarified is why did people have such a higher retention in treatment? who were on Camprosert. So placebo was lower retention treatment. People had no clue what they were on. That is one of the few medications where I feel really comfortable saying that the double blind works, and still there was a much higher retention. And since it's an NMDA or a glutamatergic substance, I feel that maybe it has an effect on changing the so to say prefrontal subcortical interaction. Nobody has ever tested that, and I think that would be something of interest, for example, to see if through that effect, that is the mediator of the effect of a Camprosert. Inhibition of inappropriate action, we have heard about that, and that is, so to say, big area of the impulsivity. We have heard several speakers indicating that, you can work on that. Newer approaches are certain computer games, which can be helpful, or it has been shown that actually things like sports activity, like batting practice, have an effect. And we have heard of several medications here which might be effective. That is, I think, an area which will be evolving and developing to have like internet specific training programs for these specific deficits. And regulation emotion is a prefrontal cortex issue. And I mean, dialectic behavior therapy is targeted towards this. And actually, again, the question is, when you have a substance like lithium, what specifically is changing? Is it the impulsivity? Is it well, emotional regulation? And I think we can learn more if we look more specifically at these effects. So let me summarize what I think actually might be more helpful than looking at disorder-specific intervention and disorder-specific medication is having deficit-specific assessment-based intervention. And I think we need to develop the assessments and the response tools. And I think also currently there's a lot of talk about medication and intervention, but again, we have at the moment only very little information and very little research into the interaction of specific substances and specific methods. This is one which is currently researched. And the conclusion is that childhood traumatization and continued lifetime traumatization need to be addressed appropriately. Cognitive processes seem to be mediators of increased risk of mental disorders and addiction after exposure to trauma and other stressors. And cognitive processes constitute central components of addiction and mental disorders. They are measurable and potential targets of treatment. And I think, for example, there was a discussion beforehand. Ivan asked the question of biomarkers, thank you, of biomarkers. And I think, cognitive measures can constitute some form, so to say, of biomarkers. They are easy to do. At least they are often easier to do than certain like fMRI or more other neuroimaging approaches. And I think we are currently still thinking too much of cognitive processes as being a kind of add-on and being somehow, also part of the same. I think we were not really realizing the potential of the cognitive process constituting a very central part of the addiction process. Okay, thank you very much.